All right, we're going to get started. We're just going to do a kind of quick introduction of the speakers, and then actually kind of, I know you guys have already started introducing yourselves. We'll kind of go around the room a little bit and get an idea of who's in the room, what roles people have. I will say there's a couple of speakers that last minute had to step out, so I'm doing the first set of slides. They're not mine, so I'll work through it, but please forgive me. So we do have to do the conflict of interest. So Jules Jung, who will be here later, she's actually on the she's SAEM board. So she's got some meetings she's got to go to this morning, so she'll be a little later, but she does have a little quarterly royalty from this website for, but does not do any assessment products, and that's what she's working on. The rest of us are actively looking for conflict of interest, but do not have any at this point. So I'm Joe House. I'm the Clerkship Director at University of Michigan. I've been there for, I think, 11 years now. I did EM residency and then fellowship in Peds Emergency Medicine, so I do adult and pediatrics there. I don't know if Will, if you want to.
Yeah, I'm Will Peterson. I'm at University of Michigan, assistant director, so I did a fellowship at Michigan.
Hi everyone, I'm Luan, Lawson. I'm a senior associate dean for medical education student affairs at Virginia Commonwealth, and I'm the clerkship or covering clerkship director.
Hi, I'm Malone. I am the assistant clerkship director for the advanced management hospital here on the clerkship, which is EM and the SLOE at Ohio State. So I help with both of those clerkships, and I know them from
I'm Erica Ross. I went to OSU for residency. I am a brand new clerkship director at the Mercy Health System. I'm Lisa Armstrong. I am the clerkship director and the PCR director at I'm Kelsey. I work at the NSA for today. I'm a advisory board here at OSU. Very briefly, I'm about a fellowship at My name is Lauren. I'm at Learning University. I'm the clerkship director at MHPE.
I'm Sean. I also am fellowship trained like so many other people in this room, it seems like. And I just took over as a co-clerkship director at the Round Rock campus at Texas.
So the other thing you get a sense of, I mean, so obviously running a clerkship is very broad in scope, and even just the clerkship direct, itself. Some have three-year programs, some have four-year programs, some's required, some it's elective. Who has as the EM as an elective? So just one. So everybody else is required. So you're like, okay, so we got a couple elective. Who has a third-year clerkship? Okay. Who has a fourth? So everybody else is a fourth year. Okay. And then mine is mixed, is how mine is. So the way the University of Michigan does it is they do your 1 year preclinical, then you have your required rotations. So my students can actually come through in like the last 18 months. So I'll have some students who are, coming through in April and graduating in a month, and other students that are coming through in November who still have, 16 months before they graduate. So we're just going to kind of talk about some of the broad strokes. And so again, so Kendra, who unfortunately can't be here today, I'm the assistant dean for undergraduate medical education. She's the clerkship director at Vanderbilt. So we're going to talk a little bit about some learning strategies. And again, I want this to be interactive, so please, if you have any questions, speak up. And then if you have any different perspectives, or if you guys have things that work for you guys, because again, that's the other benefit of being an SAEM in general, but being kind of in this meeting, what works for one person may not work for another. Someone else may have something that works great for them, and kind of that share of ideas. So again, lecture is a lecture dead, utilizing active learning strategies. So what is active learning? Are you sitting up? Obviously, this is not, what we're doing right now is not considered active learning. Kind of sitting up on front with my slides that I'm going through as people are falling asleep in the room. Again, this is smaller, so hopefully people don't fall asleep. Versus, are you more of a guide on the side? Are you more where the students are kind of learning from each other, teaching each other, and you're there to kind of guide the education? with the kind of being an active learner, you're still going to have like your goals for the session. So I really want, so we've tried to move to a little more active, and actually Will Peterson does one in regards to chest pain. And instead of doing a lecture about, how the emergency department runs and what our thought process is, you actually do it more case-based. So chest pain and kind of going through that process. And, at least for our students and probably for a lot of people's students, coming to the ED and thinking, what's the worst case scenario? That's a different mindset than what a lot of people have in other ones. They go to medicine and say, okay, what's the diagnosis? What's most likely? Where they show up for our rotation, it's like, okay, the chest pain, what's going to kill them kind of thing. And along with that, then by going through a case, it sticks with them a little bit more. Kind of redirect them, like, yes, chest pain, thinking about pericarditis, but what else do you think about? Or thinking about costochondritis, whatever else. So again, trying to be a little more active with that. Egyptian proverb, so true teaching is not an accumulation of knowledge, it's awakening of consciousness which grow through successive stages. So that's the other thing with being, having it more active is in some ways it is a little more difficult for teaching, because you are going to have, as we talked about, I've got students who are getting ready to graduate and other students who, have just finished their core rotations and still have 18 months of development to do. So kind of trying to meet these students at their different, at their own stages can sometimes make it more difficult. So like I kind of talked about, kind of having the goals of the classroom. So contextualize content, explain difficult concepts, improve student learning from remembering to applying, and then, going from memorizing, again, which they're doing at preclinical, actually applying some of that when you're talking about what their differential is, and then actually, if you have that opportunity, again, depending on where your students are, actually, kind of having okay, so now that we've gone through what's your differential, what kind of workup do you want to do? Hey, here's some results. Or how do you actually analyze those to come up with a diagnosis? And then promote reflection on content and emotional aspects of learning. And then, again, that can help facilitate your learning. So again, some of the general principles of instructional design. So making sure it's congruent with your learning objectives. And again, I was talking with Luan and Lawson about some of the LCME things. And again, this is one of the things you'll need to do is make sure that you have your learning objectives, and are you reaching those objectives? How are you measuring those objectives? So having multiple instructional strategies, and then consider available resources. So for us, when prior to COVID, we had our 2 days of lectures to start the rotation. Kind of sat like this. We tried to make things a little more active, which some people were great at doing it, because it does take a little more work for the instructor. It's easy for me to kind of sit up here and read from my slides, especially when it's got the little, the presenter mode down here, where again, trying to meet those students with that, a little more work to it. But again, think about what other resources. So what we did is, obviously when COVID hit, we went virtual for everything. So again, what are out there? Are you going to completely recreate your lectures in a more virtual format? Are you going to do it in a Zoom format? Are you going to, again, what resources are available? So we actually started going through, or having the students go through the CDEM curriculum. 'Cause that was, honestly, it was the easiest and the cheapest for me to do, and I'm lazy, so that's what I did. And then we actually looked at it, and our students actually did about the same, if not better, on their exam. So obviously, they weren't learning much by me standing in front of them teaching them. So we actually stopped doing that. When we came back after COVID, getting in person, we have an orientation lecture, which I've actually now also made virtual. They get to watch that video. I do a 30-minute talk about, okay, what questions do people have? Again, Will Peterson does his talk a little bit about, how do you create a differential? And then we have Mike Cole, another assistant clerkship director. He goes through a respiratory case and same sort of concepts. And then everything else is active for us. We do some suturing. We do the nurses come and talk about placing IVs and the nursing role. And then we do have a small section, like 30 minutes, on note writing. Because again, in the ED, it's a little bit different. And that's the extent of our didactics at this point. Again, really trying to go to active, trying to see what's actually helpful for them. Now again, so, yeah.
They're all virtual. Are you talking synchronous, where you have somebody giving a lecture, or are they asynchronous?
So they're asynchronous. So they're the CDEM modules. So I tell the students, like, my expectation is you're going to go through these slides. I also tell them I have actually no way of tracking to see if you actually do it. But I kind of use that because students are always asking, what's a good resource for learning? Obviously there's the books that we hand out. but again, I usually say, hey, this is a great resource for learning while you're on the rotation. It also works well, when you see a patient with that CDEM curriculum where they can just kind of pull up whatever that case is and kind of learn that online as well. So again, so some of the, if you are doing a little more of a in the classroom active, so there's the pause procedure where again, asking questions, trying to get them involved and kind of being comfortable with that pause and giving time for students to think about it and waiting for someone to speak up. There is, which is also kind of the 1 minute paper or muddiest point. So again, what questions do people have? What concerns do they have? Case-based scenarios. So again, kind of using a beginning, a middle, and end to talk through a case. Commitment exercise. So again, it's actually telling the students to commit to a diagnosis, commit to a workup. That's one of the things I talk about during my orientation is you're not going to be right because if you were, there's no reason for you to be here. So just, plant your flag, say what you think it is, and we'll kind of talk through it. There's concept maps. So again, this is something that we tried doing actually for on shift teaching, which actually Adam Nicholson had worked on, and it kind of ended up dying when we tried to get it out there, but actually, again, kind of map out that whatever that concept is, the chest pain, the shortness of breath, and kind of walk through that process. So again, trying to link knowledge to previous knowledge, pre-existing cognitive framework, partial versus full map, and then again, utilizing social media. So I know there's a lot of people who, have a case of the day that they post or other sessions like that where they, either the students will post something of that it rotates, everyone's required to post something one time during the rotation, or even, like I said, the clerkship director just has those, and some of those can even be set automated. So, every week they're going to have these, automated posts that's going to post, twice a week or whatever else. So again, there's some other ways of doing it. Oops. So there's a think, pair, share, there's role play, again, that debate, educational games, and then there's the snowball. The flipped classrooms. So again, actually giving students something to look at ahead of time. And again, I think, depending on what students are used to doing, some students are great at doing that because that's what they've done in other rotations, that they've done on other courses. And I think some students, I was talking to some other people about, mistreatment concerns from students and, sometimes expecting them to do things outside of like the normal business hours. I've seen them construe that as mistreatment is not the right word, but it doesn't make them happy, we'll say. So again, something to look at pre-class, guide them through the sheet. Then there's the, building on what they're hopefully reviewed. And again, hopefully it is review. It's tough to really do a whole lot of new learning concepts, asynchronous or have them look it over. So hopefully it's reviewing stuff from other rotations, reviewing stuff that they did preclinical. And then, reviewing it on, again, then the deeper learning or going through the classroom, and hopefully that post-classroom learning, again, that's more kind of, for at least from my standpoint, more of that actual patient care, when they're actually seeing those patients and reinforcing some of these things. So again, kind of talked about this a little already. So problem-based learning. So again, you can assign a problem to the group and have them work through it and actually have them kind of present, how they work through that patient or whatever your assigned problem was. All right. So any questions about that? I know I kind of went through a little fast. We tend to always kind of run late, so. Question? Yeah.
There's a slide in there somewhere that talks about the types of that learner-centered learning formats, and there was like role playing and some other things. Did you be able to go back to that slide? Oh wait, sorry.
Am I going, which one?
One more.
This one?
Is, what is think, pair, share?
So having experience with the think, pair, share?
So I think that's like if we posed a question like, discuss potential ways within your clerkship that you would increase your active learning, and then we would ask you to talk with a neighbor and discuss it, and then sort of report back out to the group.
Yeah, and when I was reviewing these slides, again, I actually had to look up the law. It's not something that I next person kind of, builds on top of that sort of thing.
I wanted to throw in observations about this in general. I think there's been sort of, we've observed sort of a shift in most of the mentality of it, and it's maybe our institution and a bit anecdotal, but it does seem like, especially moving from the several exposures to virtual lectures and lectures, especially it seems like there's this mentality of if we're going to be in person, why we need to do it in person? Why can't we just do something else? And so one of the ways that we adapt more skills that we do in the evaluation systems is really well is at the introduction part, which is going to be asynchronous as opposed to mentioning, so that they give them the logistic stuff is still on board and phone. And then when they come in, it's interactive from the start of the day. Actually start with the IB workshop, they're put the schedule for the entities that you try to get off of the like that. At the very start of the day, it's interactive with the organization. And then even with our lectures, the format we use, instead of just sort of, here's a summary of medical knowledge related to chest pain, we start with a case where we say, you're in charge, you're going to take on the problem and solution, and then you can look at those questions. We had a 23-year-old patient with a chest pain. Go. What do you do? And just put them on the spot. And we would still all work together and share that. You could go over and use that patient needs there, or you could just, if you have an interactive group or a set of time, just start from there and have them start to participate. And then one other piece, I found that medicine seems to be very engaged when you're pushing the limits of their medical knowledge. So if you're asking them for differential chest pain, they might get the rattle off differential respiration. And we should reinforce that and talk about how to look different inputs like the internal medicine, for example. But where I think we really start to keep their attention and pushing forward is when we start saying, okay, worry about virus. What are some potential complications? Some perfusion. And then you say, when is that going to matter? And show them an ultrasound image and that myocardial perfusion matters because that is that's not accurate. And so this is sort of the beyond the second level of training and clerkship. But if you're pushing them to think at those levels, I think that they really absorb and appreciate that and engage in the rest of the day if you sort of set that up.
Any other questions? All right. So now this is kind of, so again, a lot of you guys have a required rotation. So obviously you're going to have people who are not going into emergency medicine. And sometimes this can be a great experience, and sometimes you can have students who are maybe less engaged, less interested, especially if it's after match, and you can kind of sometimes struggle with those. So kind of overall, so how do people feel about the I saw a couple of heads shaking. When you're talking to those students who are not going into emergency medicine, post-match, like what kind of feelings does that kind of bring about? Anybody? Yeah, you got sigh like, oh my God. Okay. Yeah, I had one student who actually said they learned the most on emergency medicine because it was after match and they didn't have to worry about their grade. They said, I didn't have to worry about performing, didn't have to worry about any of that part. I could just learn. Yep. So about the, so what are some of maybe the benefits of having someone who's not going in emergency medicine? On your rotation. Okay. Any other benefits? That's it? Yeah. And I've seen some people or some places will do it where, they have the one rotation that's for everybody. Again, maybe more generalized concepts, and then you have that more specialized in emergency medicine as a second rotation and whatnot. So it's kind of one way I know some places kind of deal with that. I just don't have the capacity to do that at Michigan. So everybody's lumped in together. So the students who are, want that SLOE for their application is sitting right next to that student who, going into neurosurgery and emergency medicine is beneath them. So, So when you kind of separate that out, is just by advising, you're telling the students, hey, this is when you should take it? Because like our students can sign up for it, again, like I said, they have that time frame. They can sign up whenever they want, so. Okay. Okay. All right, so again, this is something that obviously you're gonna need to plan out for, so again, how are you going to get them involved? It's not something, more of a proactive versus reactive. Again, so kind of flipping the script and changing your mindset. So you want to cultivate a desire for non-EM bound students, see it as an opportunity, maybe grow yourself as an educator, versus a challenge where, again, that big sigh, like, oh my God, it's another one. And we kind of talked about this already a little bit, and, that student motivation over time. You see that dip, kind of that January time frame where, they're done with their interviews, or they haven't matched yet, they've, maybe a little burned out depending on how many interviews they've gone on, they're applying to 50 spots and going on that many interviews, especially virtually. I've heard of people doing 3 interviews in a single day virtually with the different time zones and things like that. So again, what their interest is. I usually say then at the end of the year you get that, oh shit, I'm going to be an intern in a couple of months, and now I'm going to pay attention, and now I want to learn. And I think that was kind of mentioned with that motivation at the end, later on. And like I said, so there's a difference. If it's M3 required versus elective, you're going to have those students more engaged. Is it early on where you have that student who, they're going to be a neurosurgeon, and then they do their EM rotation, like, oh wait, this isn't what I expected. So that's the other thing to kind of keep open. We have actually a fair amount of our students this year. Obviously we've seen that dip this year in applications. Next year the thought is it's going to probably be even worse. So we have a lot of students not thinking about EM when they come to us, and then, this isn't what I expected. I really like this. And so I probably have seen more students not interested in EM who are now interested in EM than I had previously. So again, some of the benefits. So, the influence, especially selection. So again, you sometimes have those students who decide last minute, like, oh, this isn't what I expected. Maybe I'm interested in it. I had one student who the Monday after match asked how to switch into EM. I was like, well, it's kind of a little late. Admitted it was a student that I don't think EM was right for them anyways, so I didn't really encourage them. But I have had that, hey, I wish I would have done this earlier kind of thing. Impact students' view. So kind of as part of the orientation, I kind of am very upfront. Some of you guys are, depending on the time of the year, none of you guys are going into emergency medicine, but you're going to come down to the department on a rotation. You're going to come down to the department as a consultant. You're going to, there's that sense sometimes like, oh, you consult us on these patients all the time. Do we really? So again, what are the patients that we're seeing? So yeah, so truly trying to kind of say, this is what you can get out of this rotation. What are the patients like? I also bring up to them, I remember my ortho rotation where it was, 2 in the morning, get that page from nursing for your 2-day post-op patient with chest pain. So again, kind of put that, so what are you going to do in those situations? Literally my attending said, what did cardiologist say? I'm like, I actually didn't call them because their EKG was fine and labs. Okay, we'll consult in the morning. But again, when do you need to call them? So again, this is what I try to form this rotation for those non-EM rotators. What are you going to do in these situations? What are you going to do when, is that call on the plane, asking for a doctor kind of thing. Also promote some collaboration. And then the other thing it does provide is, this kind of seat at the table. What I mean by that is, when you're required rotation, you're often more involved in the medical school. So you can kind of help with, some of, again, there's pluses and minuses. The LCME is a plus or a minus, depending on how you look at it. And Dr. Lawson is going to talk about that a little bit later. But it's still, you're gonna have a little more influence in the medical school. You know, you're gonna have the ability, hopefully, to get some support and growth for yourself. You know, I've collaborated with several of our other specialties and, you know, for publications and presentations. You know, they have the statisticians sometimes in the medical school for grading. I've got a couple of publications with them. You know, so again, being that record rotation, taking all the students, there are, like I said, benefits for that too. So, oh, go ahead.
The other thing on the seat at the table point, a lot of medical schools, mine is the one specifically talked about here, but a lot of the competencies that need to be sort of assessed, and a lot of the, especially in a lot of EPAs, especially EPA 10, are really suited towards the emergency medicine clerkship, and these competencies EPAs are for all students, not just the EPAs students, so you can take the opportunity to sort of own and develop curriculum and assessment for competencies that can fill your entire medical school requirement. So it is a really good opportunity.
Yeah, so as kind of Matt talked about, so evaluate the patient on differentiated presenting problems. Again, they can learn to do a focus H&P, and they got down there at the bottom, that EPA 10. Because again, a lot of the other specialties, you know, just, you know, they're, again, patients have already been seen, they've already been evaluated. So again, it gives us that opportunity to, you know, develop that, take ownership of that sort of thing. We're talking about system-based practice, so again, prioritizing tasks in the healthcare system. I mean, I was just reading on Facebook on how this morning, I probed through it, you know, about, you know, patients sent to the ED for dental pain. They talked to the dentist. Why? Because I didn't know what else to do. You know, then patient came in because they wanted their surgery now versus waiting for it. So we see all those issues. We see the social issues. And again, it's you know, helpful to kind of point out to the students. One thing I always talk to our students, we have a direct observation requirement in regards to communication and information sharing, we call it. And so I talk to students like, again, yes, in the emergency department, this is what we want, but it can go across. I mean, I'm sure we've all seen the patients who just got discharged from the hospital, but then show up in the ED because they, you know, I remember literally this little old lady who went to Myers, one of our local stores, waiting for a prescription, checked her blood pressure was high, so she checked it again, it was higher, checked it again, it was higher, so came right back to the ED. And literally she was like, I didn't know how high was too high. So we let her sit in bed for 10 minutes, or for, I think she was there for an hour and then discharged her because her blood pressure got better. But again, so again, way to kind of form, these are the things that work a lot in the ED, because again, it does cross. So some of the ED processes, the ED's role in healthcare, and again, it also gives that opportunity for interprofessional and team communication. So we actually have, besides for the requirement with the nursing at orientation, like I said, they come, they talk about what their role is in the ED. We do some procedures. They used to do the model with Foley placement. We actually have this, for the students who are willing, start IVs on each other to get that practice. And again, so there's some teaching by the nurses. And then we actually have a requirement for a rotation that the students spend at least a half day with nursing. Again, sometimes they're doing IV, sometimes they're out in triage. We also used to do it with social work and pharmacy, except for because of capacity issues, because of more pharmacy and social work students, we aren't able to do that anymore. But again, it was a great way where, you know, the student gets to see, okay, what's social work role, what's pharmacy role. So again, depending on how you're set up, this may be another great opportunity to get involved. And believe me, you know, if you can do some great IP experiences, the med school will love you. And then problem-based learning. So again, you know, like Will kind of talked about, you know, pushing your students to you know, to their limit. You know, so again, okay, so now you don't know what to do in the steps. What opportunities are? What resources do you have? What can you kind of look up in those areas? So learning environment. So Matt's going to talk a little bit more about the learning environment a little bit later. But again, having clear expectations. You know, you yourself having that good attitude. Using different learner concepts and approaches. You know, optimizing the learning environment. And then foster intrinsic motivation. So like I said, that intrinsic motivation is, again, how does it relate to what you're doing or what they're doing? So again, try to set the clear expectations in regards to both the clinical and the non-clinical components. You know, we talked a little bit about this already, so orientate students to the course itself, the ED, and then emphasize so it's translatable to whatever day I'm going into, so the benefits of the ED rotation. So then, like I said, then in ourselves, I mean, like I said, you see those non-rotators, sometimes again, you get that, oh, you're going into blah, blah, blah specialty, and the students can sense that, when you do have that different response to them. I've had, I'm sure we probably all have had students saying like, oh, well, when I told them I was going into such, to X specialty, they seemed less involved, less engaged. And depending on the shift, I can't say if that's actually true or it's just a busy shift and you got involved in that, but again, that's that perception that students have. So again, not just us as educators, us as clerkship directors, being motivated to teach these but then also, making sure that our faculty, our residents, whoever's doing your instructions are also kind of motivated and have a good attitude for those students. So again, being open and approachable, being enthusiastic, treating students with respect, again, knowing their name and their specialty, acknowledge their past experiences, and again, their presence on shift. So again, kind of talk about this a little bit. So getting to know your students, plan to encourage self-directed learning. So again, making sure they know what opportunities are out there, what options are out there. Potentially if you have the capabilities, can you individualize their curriculum a little bit? So again, what interests you? What do you want to see? That sort of thing. So again, I tell my students, if you're going into ortho, I don't want you, obviously you're just seeing ortho complaints. I want you to see the chest pain, the belly pain. So again, making sure they're getting that broad experience. But again, like I said, kind of painting it into this is why I want you to see these other things, because that's why, those are the calls you're getting in the middle of the night. The chest pains, the belly pains, the 3-day post-ops, whatever it is. And then again, if you have the opportunity, some of the bedside teaching techniques. So the 1-minute preceptor, snaps, among some other ones. Yeah, I do ask my students, they have a little form that they're supposed to fill out. I don't collect it or anything like that. And I try to readdress it at mid-rotation time, exactly that, kind of what are your goals? What do you want to work on? Now, I don't think I've ever had any that are very specific to what they're going into, though. I mean, they're a lot more vague. I want to see sick versus not sick. I want to see traumas, stuff like that. But again, I think, again, trying to tie it into what specialty they're going into at that, even reinforcing it at that mid-rotation time can help. So again, this is kind of reflect, so this is, supposed to be, kind of thinking back, I'm sure we all had those rotations when we were in med school that we really loved and other ones that just kind of were not great experiences. And kind of thinking about what made those experiences great. Like I remember one where I was on a OB rotation, and I felt very disconnected from my team. Primary language for a couple of the students I was with, and then my senior resident, was not English. And oftentimes while we'd be sitting in a group session, they were speaking in their native tongue. It's kind of like, it'd be great to be involved, and you definitely get that sense of, why am I here, and kind of that no one wants me here, and again, it does affect your learning. So again, kind of thinking back to those and making sure that, everybody feels involved and engaged. And again, thinking about optimizing learning. So creating and maintaining a positive learning environment that's supportive, but then also challenge your students. So kind of as Will brought up, if you're teaching everybody, kind of basic medical education, they're not going to get anything out of it. We're really kind of to push them. Now, obviously, there's been, publications and concerns of pushing students too far, and is it mistreatment, is it pimping? I think in general, as long as you, either kind of, again, give them the expectations. You know what? I'm going to ask you questions, and I want to kind of find out what the limit of your learning is. I want to push you to the next limit. That's a different than just kind of throwing questions at them until they can't get the answer, right? So again, setting that as expectations, so that way you can support them, but then also challenge them. Now, the other thing would be, she's got on here is kind of being mindful of professional humor. In the ED, obviously, it's a very different environment than some of these other specialties. We do all have kind of our own sense of humor of I don't want to say what's allowed, but of what's allowed in the department. So now you've got someone who's not necessarily the chosen field, who's a new experience. And again, some of this goes with our students who even are going to EM. It's a different experience, so just kind of being mindful of that, of what people are saying. And, if someone's, saying something and then being willing to speak up and say, hey, I have one faculty member and who, every female's a chick. It's like, come on, man. He goes, oh, am I going to get another write-up for this? I'm like, I don't know, but just don't do it. He's had, he's got other things too, and I'm sure both of you guys know, both the ones that rotated, or both our EM grads know who I'm talking about. But again, just being willing to kind of speak up and make them think about what they're saying. Again, these jokes and things like that, and sometimes putting it in perspective. I've had some students complain about the frequent flyer, sort of thing. And it's a term I think a lot of us use, but to that student, it was a negative connotation. So again, actions speak louder than words. Kind of talked about this already. So again, motivation. Again, what are they there for? So again, fostering their intrinsic motivation, emphasizing the value of the overall course. Like I said, kind of pulling it back to what are they interested in, what are they going into, and how does your rotation relate? I'm going to skip over these. So again, conclusion. So again, having a non-EM can be beneficial to you in the specialty. Having a plan for those students, setting in communication, clear expectations, having a good attitude, using learner-centered approaches, and optimizing a learning environment to foster. So we've kind of had a lot of questions like during the presentation, but any other questions at all? All right. Matt, I think you're up next.
So I'm going to talk about the learning environment as it pertains to EM clerkships. A lot of what we're going to be talking about is somewhat specific to required clerkships, but I think that there are pearls of wisdom for all kinds of clerkships, whether they be fourth-year boot camps or third-year electives or however your institution has set up your EM clerkship. So we're going to define the learning environment, and we're going to talk about Standard 3 of the LCME, which pertains to the learning environment. We're going to describe some positive and negative features of the learning environment, including trainee mistreatment, and identify some strategies to improve and optimize the learning environment for your clerkship. So let's start with what is the learning environment. So the learning environment is the structural and social context where the learners learn, and this environment will influence their behavior, their emotions, and their performance. This is slightly different than the learning climate, which is how students experience or perceive the learning environment. I think it's important to note that two different students can experience the same learning environment but perceive a different learning climate, but you should also keep in mind that two students can have a different learning environment. Whether it's a learner issue or the teacher that they're specifically with, no two students' experiences are going to be objectively the same, and oftentimes, even if they are very, very close, they will be perceived differently. So there are a number of elements that affect the learning environment, some of which you can control and some of which you can't. The materials, your teaching methods, your schedule, some of which you're going to have some control over, things like your assessment methods, et cetera. But there are some aspects of the learning environment that you may not have a lot of control over. If your clerkship physical location is in a sort of bad neighborhood and students aren't feeling safe. If you sort of think of Maslow's hierarchy of needs, so like down at the bottom is like physiologic safeness, you know, things like food, water, shelter. You know, those things, if they don't have those first, they're probably not going to be able to appreciate things higher on the pyramid. You know, and there are a few things, like you may not have a budget for food, right? But it also may be a good idea to, or maybe a bad idea to schedule 4 hours of lectures in the middle of the day and not allow the students an opportunity to eat. So just a few things to keep in mind. An ideal learning environment is welcoming and respectful, and that's sort of mutual respect for both the students, the faculty, and the staff, and everybody's getting along. You want it to be trusting and engaging, but it can't be so familiar that that the things like assessments and whatnot go by the wayside. It should be student-oriented, which we've already sort of touched on, and it should be cooperative and team-oriented, and hopefully allowing for some interprofessional engagement as well. A poor learning environment often has a culture of fear, excessive workload, or the type of work that students perceive as not being particularly helpful or engaging. And if students aren't able to express their views about the learning environment, it can also affect their perception. So these are, in general, things to avoid. So now we're going to go into some specifics. Again, these are most applicable to clerkships that are required and have LCME visits and things like that, but in general, you should be able to apply some of these things to any of your rotations. So the LCME requires that medical schools ensure that educational programs occur in professional, respectful, and intellectually stimulating academic and clinical environments, that those environments recognize the benefits of diversity and promote attainment of competencies required of future physicians. So what does that mean? The LCME breaks it down into 6 subgroups. The first 4 I'm just going to tell you about, and you should be aware of them, but they may not be applicable at all to your specific clerkship, but they are to the sort of general curriculum of the medical schools in general. So LCME Standard 3.1 requires that medical students have some exposure to residents in the clinical environment. It does not mean that you have to have residents at all of your sites. It just means at some point, students need to work with resident learners as part of their program. Similarly, LCME Standard 3.2 requires that medical education programs are conducted in an environment that promotes scholarship and have opportunities for participation in research. Again, your specific clerkship does not need to do this, but it is a requirement of the sort of your institutions as a whole. LCME Standard 3.3 and 3.4. 3.3 requires that there be some sort of diversity pipeline program and partnership that is actively aiming to achieve diversity among applicants to medical school as well as faculty and staff. And then LCME Standard 3.4 requires that a medical school does not discriminate based on age, race, creed, gender identity, national origin, race, sex, or sexual orientation. So all of these should be present at your institution level, and they are standards that you should be aware of. So there's a lot of different ways you could do this. So OSU has, this is just one example. We have a MedPath program, which is sort of a MD, PhD program that is a pipeline towards faculty status. So the idea is they recruit students to be physician scholars with opportunities for sort of with opportunities and sort of expectation of having jobs down the line. This is not how every medical school does it, but you just have to have some sort of process in place. All right. The next 3.5 and 3.6 are the ones that we're going to be talking about in most detail and are definitely applicable to your clerkship kind of regardless of its structure. So standard 3.5 addresses the learning environment and professionalism specifically. It requires a medical school to ensure that the learning environment is conducive to the ongoing development of explicit and appropriate professional behaviors in its students, faculty, and staff, and that all individuals are treated with respect. The medical school and its affiliates share the responsibility for periodic evaluation of the learning environment in order to identify positive and negative influences on maintenance of professional standards. So the key thing that I want you to sort of, or the thing I want you to key in on is that if you are a required clerkship and you're having an LCME visit, at some point you're going to have to do an evaluation of your program and its learning environment, such that you have questions in your end of shift or end of rotation evaluations that specifically speak to professional behaviors and respect. And we'll get into a little bit more of that here in a second. And then 3.6 is student mistreatment. And in short, it requires that there's some sort of mechanism for reporting violations of the Code of Professional Conduct at your institution, and that this mechanism is well understood by the students and ensures that any violation can be investigated without fear of retaliation. So we're going to talk about a little bit more in detail how this can be done. So if you're having an LCME visit, or if you just want to make sure your learning environment is conducive to the education of your learners, it may be a good idea to put some questions in your end of shift or end of rotation evaluations, and here are a few examples of what we use at Ohio State. So the faculty, healthcare team, and other staff on this assignment created an environment that promoted appropriate professional values, and hopefully all of your students are going to answer agree or strongly agree. Students were treated with respect. And these, again, are specific to the rotation, but we'll get into some about specific individual faculty as well. And did you feel supervision of you as a student in this course or clerkship was sufficient to promote a safe environment for you and your patient? So again, we're professional, so these 3 questions are specific to professional values, respect, and then a safe environment for learning and patient care. You can also ask specific questions, such as in a standardized evaluation of a clinical instructor or end of shift evaluation of the teacher itself. So the teacher treated me with respect, and the teacher treated others with respect. So this is, these are opportunities to identify faculty that are really, really good at this, and that we should all model our behavior after, and it may also give you some insights into specific individuals that have created a pattern, let's say, of not being respectful to students or not demonstrating professional values. Just a shout out to Dr. House here. When you do track these, when you track the data in your learning environment, it has been shown, at least in his study, that it can improve student perception and the objective sort of reality of the learning environment. So there is benefit to it. You know, if you're asking students, they're going to think about it more. And if your faculty know that they have specific questions on these end of shift evaluations dealing with SPECT and professional values, they're more likely to behave accordingly. So at Ohio State, we have a student mistreatment reporting system. You know, if you all have access to these slides later on, you can go through and look at this. But we call it the big red button, and you don't want to be on the other end of that. So the students are all very aware of how to do this reporting. It's ensured that it is anonymous if they want it to be, and that that it is free from a fear of retaliation or reprisal. In addition to your specific institution, end of shift evaluations or evaluation of clinical instructors, the AAMC graduation questionnaire is another really great opportunity to get some data on your specific learning environment. And it may be specific, there may be some specific attributes contributed to your specific clerkship, but it also may be the general learning environment of your institution. This has been collected, or going on 30 or 20 years or 30 years now, and asks a number of questions, including if the students experience any specific types of mistreatment, who the source of that mistreatment was, how it was reported, what actions were taken, and if the students witnessed any mistreatment of other students or staff. And again, I just included this so you can go through this questionnaire at your own leisure. But if you look up here, there is a lot of several questions that deal with the learning environment topics that we've just talked about, such as being respectful to house staff and other physicians, respecting diversity, being respectful of other specialties beyond your own, et cetera. And then there are some specific behaviors that they look at. So have you ever been humiliated, embarrassed, threatened, or physically harmed? Have you ever been required to do any personal services? Have you been subject to sexual advances? Have you ever been denied training or reward based on, not complying with any of these requests, et cetera? And then again, there are a number of questions about have you ever been mistreated based on your sexual orientation, race, creed, et cetera. So if your specific rotation doesn't necessarily need to have those questions, but your institution will collect that data from every graduating medical student. And then they will be given opportunities to explain. So while it doesn't ask specifically, did you feel mistreatment in your emergency medicine clerkship? If they answer yes to I was publicly humiliated, they will have an opportunity to explain to the AAMC specifically what it was in your emergency medicine clerkship that led to their humiliation. All right. So there's a few other things that I want to talk about. So I want to talk about the gender and sexual harassment and a few other very specific things because they have a little bit different reporting. So beyond, beyond specific gender or sexual orientation, there are stereotypes that come with a lot of our specialties. And there can be perceived preferences or favoritism in such cases, and these are things that we should probably avoid. there are specific instances that may not seem huge that can show up on these either end of shift or end of rotation evaluations or on the AAMC graduation questionnaire. You know, things like aggressive questioning or belittling, or doing personal services may not, you know, these students may perceive this as a bigger deal than you do. So we all have to sort of be very vigilant about how we're behaving and how our learners are perceiving us. And we'll go over a few cases here in a minute about these specifically. The other types of mistreatment can be really subtle or hidden. So things like neglect, which is not benign, or even sort of lack of civility between specialties. So if you're complaining about, you know, the neurosurgeons and how long it takes for them to get rotations or how long, consults, et cetera, even if that student isn't going into neurosurgery, they may know somebody who is, or they may just take that lack of sort of civility as a problem with the learning environment in the clerkship or in the department. And then there are specific marginalized learners that we need to make sure that that our biases don't come into play. Things like gender, sexual orientation, even political and social views can be really hot topics that we may need to avoid. And then sort of last is the romantic and sexual harassment stuff. So in general, romantic relationships between individuals in a supervisory role or teaching role are a conflict of interest. Now those can, in many cases, can be present. For instance, like our faculty, there is a resident that is married to an attending. They knew about that sort of going in. So that specific faculty member does not oversee his wife in any advising or clinical capacity. And that, in addition, the person in the position of power in the institution has the responsibility to eliminate that conflict of interest. So if there is a romantic relationship, it's the responsibility of the faculty to make sure that that does not affect the learning environment for their students. And then the last thing I want to talk about is sexual harassment, which is a little bit more specific because of Title IX. So sexual harassment is any unwelcome sexual advances, requests for sexual favors, physical or verbal conduct of a sexual nature that is unreasonably interfering with an individual's work or academic performance. This is probably a bigger problem than we, even now that we realize, although it's fortunately coming into light. But the thing that I want to highlight here is that there are specific reporting requirements for sexual harassment in academic institutions, so I highly advise you to discuss with your human resources department if issues of sexual harassment come up. For instance, if a student comes up to you and says, hey, I'm really worried about this behavior, it may be a good idea to explain to the student that, you know, I'm really glad that you came to me, but you know, the things that you say I am required to pass on because of Title IX, and I'll have to report it as a mandatory reporter. All right, so we're gonna do a few cases, and I hope these aren't too hard, difficult, or, and bring some good conversation. So case number one, you're hearing a medical student present to a team, and there's a male patient who is HIV positive. The resident asked the student if the patient is gay and if he is a pitcher or a catcher. The student is visibly uncomfortable, says he doesn't know. The resident, chiding and kidding, then begins about guessing the answers to the question. As the attending, how do you approach this situation? Don't all speak at once.
I think you address them individually.
Okay?
Obviously, what the resident is doing seems really not professional. Addressing that separately, and then of course talking to the medical student and saying, hey, this is not the expectation that we have in this department. And, you know, not making excuses, but owning up to the issue that you noticed, but doing something about it.
Okay. So, okay. Any other thoughts? Yeah. Great. You know what I think is fascinating about this conversation? Nobody has mentioned the program director at all. Like, yeah, exactly. Yeah, this may, there may be extenuating circumstances sometime, or, but it is, if you don't establish a pattern, you'll never see it, right? So like, if I witness this and Joe witnesses this and Will witnesses this, but we never talk to each other, we never talk to program leadership, et cetera. We just have a conversation with the resident or with the student, sort of call them out. 6 months or a year down the line, and you go to the resident and say, hey, we're really worried about your behavior because, we think that there's some, bias that you have towards a specific patient population, and there's no documentation of it, nobody talked about it, the resident's gonna be like, well, prove it, type thing. So I think it is really tough because we want to give our residents sort of the benefit of the doubt. We don't want them to, be jobless after residency, and et cetera. But we also have a responsibility as their educators to, exactly.
A lot of times, especially on someone who's been a residency for 15 years, I trained in the era where people would just sort of competence side. Now it's fantastic when people are appointed in person. But the resident may not be aware of their biases. And if everyone's talking amongst themselves, they may just think that they're doing a joke and everyone goes with laughter.
Yeah,
Unless you would physically address it and have them, like,
absolutely.
think about it, they're not gonna, they may not.
So how would the scenario change if you saw it on an end of rotation evaluation as opposed to seeing it in real time? So let's say you're going through the evaluations or somebody hits the big red button that I was talking about and says, so-and-so resident said this thing to me and it made me really uncomfortable, and they submitted it anonymously. So how would that change how you address the situation? And it might not.
Well, I mean, you'll have the ability to kind of do it real time. Student account. From the student perspective, they're not going to know if it was done, what was done. I've had somebody even, like, I can't make sure that the program director knows about it. I've told the individual resident in my office, kind of talk about it. And say, I wasn't there, but this is what the report was, what was written about. What I do every year is when I talk to our faculty about kind of overall performance, is I pull up things that these guys pick up on work before. I make sure that we're in those discussions with our faculty, that maybe you're making sure that
I think some of the challenges are, it's one thing, so I think if you don't have a discussion real time, then the perception of the student is that you're condemning behavior. I think when it gets reported anonymously, you can have those discussions. I would say frequently, though, I think as the clerkship director, the students come and say, hey, I had this experience, I think people are trying to be funny, I'm not really sure how to. And so sometimes you actually get some of these things as the clerkship director, where people come to you directly. And I think it's really challenging because I think sometimes you're like, that seems like the nicest person in the world. I don't think they would ever do anything like this. But then it's really helpful to keep a list of some of those things that go ahead and have those discussions and really track that, because sometimes you can end up with tremendously large problems that you're just catching little glimpses of them at the time. Because for the most part, I would say it usually ends up being a pretty large thing for people sometimes to report it to that anonymous, to the larger scale practice. You're getting hints of it along the way as the director. So you're dealing with those sooner rather than later. I mean, the goal is to prevent that, to help somebody in their career. So whether it's to be able to recognize what their unconscious bias was, but to really provide them feedback and be able to stop that behavior.
anybody brought up that didn't have a big red button or whatever your guys call it, just said they think it was weird. So I actually tell them, like, I tell them, you don't think I will, like, encourage you to submit something. I said, if it's a one-time thing, that's fine. Nothing's gonna happen. I had one faculty member who got home before, and I talked about it, and said, this is the only one, I want you to be aware of it, not really do anything about it, or anything about it. But I thought, students, if you submit something, not a big deal if you submit it, not a big deal if you submit it, not a big deal if you submit it, that's a big deal. So again, so the policy you ask students to put in writing, if it's a one-time thing, make them aware that multiple little things that happen.
All right.
One other thing, so just,
Oh, sure.
so your head wants it anonymously, but we're going to be because we're the one. A couple things we're touched on that are short related. So reaching out to the program director to message the residents and talk about this specifically the fall and the lower environment is one step. Then reaching out to the students and just rotate it. So
Great, thank you. All right, case 2. This is kind of a non-EM case, but you can apply it to EM. So during rounds, the attending arrives a little bit earlier. The resident is finishing consult and isn't there. The attending gives the student a Starbucks card and asks him to get coffee for the team while the attending finishes up co-signing notes. Is this something that anybody here has done? Would it shock you to say that the AAMC thinks this is awful and we should not be doing it? It's really funny. But if we go back to this questionnaire, come on. There is a question. Yeah. Yeah, so it's, say that again, please.
Required to perform personal services.
Yeah, so this would be considered a personal service and not a part of patient care in any way. So in general, it's not, it's a frowned upon activity, sorry. So is this different if you ask a student to go get an MRI disc or go find the transfer paperwork and have the unit clerk load them into the system, to the media, whatever. Is this something that we're allowed to do?
I mean, I'd argue you could say that maybe MRI is other responsibilities or actually focus on care and that's long, but it's really educational or probably not. So I can see either way. But you could argue it's work. It's not educational. Well, not service, but stuff.
Yeah.
My view on it is, like, it's definitely scout work, and I remember having to do stuff like this as a student, but it's also, there's a, maybe not a testable medical knowledge component of it, but it is also just like learning the basics of how medical systems work, how to move things along. So I don't think it's completely devoid of clinical value, although the student might not see it that way. I think it's okay.
Yeah, so, while the student, as you said, may not think that this is high learning value to them, it is still a thing that doctors have to do and is something that you can ask the medical student to do if you think it would be helpful. Hey, could you go get everybody coffee for us and I'll pay for it? You may think that sort of you're doing this like nice, thoughtful gesture, and it's going to bring up the morale of the team. But if you make a habit of doing that, I guarantee it's going to show up in the AAMC questionnaire because somebody's not going to like it. So it's something I would recommend against doing personal tasks that are not related to patient care. I question whether or not, if the student were to volunteer, if I would even let them do it. If they're like, hey, can I go, I'm going to run up and get coffee, can I get everybody else coffee? I would even question whether or not I would let that happen. Anybody have any thoughts on that? Execs over here?
In the old days, yes, there probably have been times when I'm like, yeah, sure, here's my credit card. Now, I think sometimes if the resident says yes, I probably don't speak up, but I definitely do not. Sort of, I just feel like it potentially lands you in a landmine that has unintended consequences, and it's just not worth it.
For such a silly thing, it's not worth it, All right.
I mean, there are other ways to do this, right? Here's some early, morale, legal.
Yeah.
Same amount.
obtaining food, coffee for residents or attending, fetching personal items, hey, I left X, Y, or Z in a room. Could you, I left my stethoscope in the room, in a room upstairs. Could you run and get it for me? All of those things are kind of off limits. All right, last case. A student on a colleague's team comes to you for advice. She stumbled up on a presentation the other day, and the attending said, well, I suppose that's okay for a blonde. Today she said, after seeing a bookish patient, I bet you like nerdy guys. You probably like to dominate them. Later she texted her and said, I suppose I shouldn't say everything I think, with a little winky smile. How is this situation different? Oh, it is. Oh, no, I mean, let me rephrase. How is this situation different than, let's say, the first situation, case 1? Yes. Exactly. Yeah, so, there's a lot of different scenarios that this could come up. I don't know if raise your hand if your institution makes you do some sort of Title IX. Yeah, so it should be most of us, if not all of us, if we have students. We're taking, 5 minutes to go through this, but, ours takes 3 hours to go through and you can't fast forward. And goes through a lot of these scenarios. So, just remember that at your institution, you probably are, if not definitely are, a mandatory reporter, and that people on off-service residence, if they have adjunct professorships with your institution, may also be required reporters. So there may be some messaging that you need to get out to your satellite, clerkship sites, things like that, to make sure that these sorts of things aren't happening, and if they are, that people are speaking up. So give me, somebody's give me an example of how they might address this specifically. Sure. biology resident who would hit me on the back of the head with his clipboard every once in a while, just to keep me in line. Not kidding. Well, thank you for the engagement and for the discussion. I really appreciate your participation. Just some end notes on some strategies for how to improve the learning environment. Anybody have any questions about the learning environment or the discussion we had? We were a little ahead